Could you address the issue about the September 1st? Because that was my understanding, and I hadn't heard that it had been pulled back. So if you could provide some clarity.
And, and absolutely the communication was not done well on this issue. And so totally agree with that and apologize for the sort of misunderstanding of how we communicated this. So the issue is that the automatic violations, in terms of the system automatically determining that there was a violation, that system change is not going to go into effect, did not go into effect for May 1st, and that's where we think that will happen in September. That doesn't mean that the standards of, if there are violations, that nothing will happen. We will be manually monitoring, which is obviously a much more challenging process, and it's not going to be every single timesheet or anything like that. But if there is egregious violations happening, we are required to do something about that. So that is the problem.
So that is very different.
No, absolutely, I understand.
So it's not that it's an extension on your grace period to September 1st. It's you needed time to get the computer system straight to do the automatic, and so, but it's not an extension on the grace period.
Right. And
that's fundamentally different than the way I understood it.
Yes.
Thank you for the clarification. Next witness.
Gary Passmore, Congress of California Seniors. First, I want to associate myself with the concerns of Deborah Doctor, and just to comment that given the small number of people we're dealing with here, I just don't understand how we could have a screw up like this. I mean, if it were 100,000 people, maybe, but it's a totally different situation.
Right. Thank you. We're going to hold this item open. Let's move on to issue 8, home and community-based services, the federal requirements.
So the specific budget request here is for resources related to the implementation of the HCBS regulations. We are requesting 3- and 4-year term limited resources to fund 10 staff in order for us to, on the department side, meet the requirements of the regulations, as well as continue work on the CBAS program and the assisted living waiver. Specifically related to the HCBS rules, the positions will be developing the appeals process, performing the on-site assessments, and working on the remedial actions to help providers come into compliance if they're not into compliance. You had several questions related to the statewide transition plan itself, so I'll talk about those. In terms of the timeline to resubmit the plan, we are still working with CMS through the technical assistance process, so I don't have an exact time frame. We are anticipating that likely we would be resubmitting in the fall. And that would include likely then a release draft out for stakeholder comment in the summertime with the 30-day comment period. The resubmission would be addressing several things, including the full systemic assessment of all of the HCBS provider settings, the detailed site-specific assessment process, the heightened scrutiny process, the continued monitoring process, as well as the remediation or corrective action plan for those who are partially or not compliant, and if needed, a plan for if members need to be relocated from those settings. In terms of the question about prioritizing assessments, obviously at the end of the day, we are required to ensure compliance for all members in residential settings, regardless of what those settings are. Those could be both in their own home or in other settings. Due to obviously the complexities and sensitivities around a state assessing someone's private home, we are making the determination that that is compliant and would not be going in and assessing someone's private home, and so we are prioritizing those places that are provider-owned or controlled, particularly looking at provider-owned or controlled residential settings, so adult residential facilities, group homes, residential care facilities for the elderly, things like that. Particularly because if there are issues, both we want to have time to have remediation, but if needed, if people do need to transition out of some of these facilities, that there's time to do that, and that's well planned out, and it's not something you can do in a month or any short period of time. So obviously part of our plan to have the sufficient resources that you asked about is what we're asking for here, is the staff and resources in order to make sure that this works well, and certainly other departments have similar resource requests in order for us to work together to coordinate and implement the final regulation. With respect to that, how we're working with the other departments, we have formed a state-level team that includes all the affected departments, so that includes DDS, Department of Aging, Department of Public Health, and the Department of Social Services, to really identify, collaborate, and design on the implementation of the plan. We have crosswalked the requirements of the plan between what the different departments do and the 11 different HCBS programs that are operated among the various departments, identifying both what are the current practices, what are the gaps, and what are the challenges going to be in implementing this, and how do we have common policies and procedures moving forward. We did create core assessment tools and processes that will serve as the baseline that all departments will be using, but certainly those then will need to be tailored to the particular programs, because again, we have 11 different HCBS programs. Through that team is how we are sharing the best practices across the departments. We have weekly meetings where the focus is on the implementation of the program, what we're doing, what's going on. As well, the department staff do attend all of the stakeholder meetings that the other departments are holding, so that we understand what's happening, what issues are being raised, and sharing that back out with the rest of the state team. With respect to the next question about whether we've determined whether any of the settings may not be compliant, at this point it's too early. We don't know that yet to be able to estimate, how big of an issue is it? Are we going to be compliant, non-compliant? I would flag, though, part of our process will be working to remediate if there are compliance issues, so that we aren't losing wholesale providers, but how do we help them come into compliance? With respect to Tennessee, actually, the staff is at a meeting this week with other states, including Tennessee. Tennessee, as noted, is the first state to have their transition plan approved, and we have been in contact with them and are learning from them this week, and staff have shared some of what they've learned. And certainly some of that will be helpful to California. Structurally, Tennessee is very different. They have a much smaller population, but beyond that, a much smaller HCBS program. They don't have as many different settings and programs that we do. They also operate all of their HCBS programs through their 10-care managed care program. If you don't know, Tennessee's Medicaid program is 100% managed care. So it is a little bit different, but we are trying to see what we can learn from them, since they were successful in getting through this process with CMS. I would note, I understand my colleagues from CMS as well, but there's been continually updated guidance, so it's been a little challenging for us to know sort of where's the line. And so we continue to work towards that, but it has been a challenging process for us. With respect to the licensing requirements, again, part of that systemic assessment that we did, that is a part of the online version today of the statewide transition plan, we did look at the various licensing and programmatic regulations to determine compliance. What we've determined so far is that the licensing requirements either comply or they don't address the issue. So there's not specific licensing requirements that are out of compliance. It's just that they could be silent on some of these issues. And so we will be working, obviously, yes, in partnership with the Department of Social Services licensing piece to identify any additional programmatic changes or policies that need to be issued to providers so that they understand what they need to do to come into compliance.
Public comment.
Hello, Aaron Carruthers, Executive Director of the State Council on Developmental Disabilities. The Council wants to applaud the Department for having a specific timeline for implementation of the final rules. The Council is a part of the work group that the Department put together, and we're glad to be part of that. And we've reached out to the Department to say the Council is uniquely positioned to be part of the solution, implementing some of the more difficult pieces of the plan, such as training and on-site reviews of providers. The Council is motivated to get this, the final rules in place, because it implements the vision of fully integrated services, but also as a reminder that the next frontier in developmental disability services self-determination waiver is contingent upon this plan and implementation. Thank you.
Thank you. Next witness.
Gary Passmore, Congress of California Seniors. Just to note that we are among a number of agencies that are watching this issue, along with the providers that will be affected by it. And we also strongly support the increment of staff at the department to oversee it and make it happen. Thanks.
Thank you. All right, let's move on to issue number 9, the California Community Transitions Demonstration Project.
Sure, so the budget ask here, again, for resources is the continuation of 5-year limited term resources to support the 8 positions that currently work on this program. The grant was extended, and that's why we're asking for the extension of the positions, that they are funded 100% by federal funds. There was a question in the agenda about the reinvestment of the general fund that is required as a part of the grant. That is split between the 3 departments who participate in this grant, so us, the Department of Developmental Services, and the Department of Social Services, and each of our departments uses the general fund savings differently to increase the individuals transitioning out of inpatient care facilities. I'll obviously only speak to DHCS since I don't want to speak for my colleagues. We reinvest the general fund savings experienced by transitioning eligible persons from skilled nursing facilities by enhancing the rate that we pay to the assisted living waiver care coordination entities. So for 1 month of care management, for every person who is transitioning out of a SNF to the assisted living waiver. So for example, the normal PM for someone not transitioning is $200. For a member transitioning from a SNF, it's $1,000. So that's how we reinvest it on our side.
LAO, Finance, Public Comment.
Deborah Doctor from Disability Rights California. This program had a degree of promise when it started, but it was always flawed because it relied only on existing services, that is the NFAH waiver, which is completely underfunded and deficient in many ways. Also, it also relies on the obligation of the nursing homes to notify the community transition provider when a resident answers affirmatively to a question on this thing called the MDS 3.0, would you like to talk to somebody about getting out of here? My friends who are in that community of providers tell me that they get very few, some of them none, calls, although we know that about 25,000 people say yes to that question, and there has never been any, as far as I know, any kind of accountability and if the nursing home staff doesn't do that. There have been other roadblocks in this program, including the difficulties to get and keep providers for this important service. And if we're saving all this money, which I am glad to hear, when it comes time to talk about the renewal of the nursing facility waiver, which is the tool that's mostly used to help these folks, I'm hoping that this committee, if you have any oversight of that, will be looking at, remembering that there's these savings and that should be invested in alternatives to institutional care. So that was kind of weedy, but there's a lot of details here and a lot of issues. Thank you.
Thank you. Next witness.
Denise Leiker, Independence at Home, a SCAN Community Service, Southern Los Angeles County. We are actually a CCT provider. We're an original provider, even back when the grant was being planned for California. My MSSP program was a site that was part of the thinking through this. And I echo the comments of Deborah Doctor, because there was a lot of promise, but there is so much red tape in this program that people really do want to get out. The nursing home stands in their way, the resources available stand in their way, and these are Herculean cases. We have transitioned in the lifetime of this program over 100 cases, but we're talking about people years and years in an institution, have given up everything or lost everything, got stuck there. But there are so many barriers in this that this has so much more promise if we could really retool that. We're committed as a site to this program. It is a huge value and a huge need, but we need a lot more help in making access available. And for my staff that are doing this on the ground, not to have to spend their time hustling up their own cases. We know there must be people out there answering that MDS question affirmatively that they want out, to remove those roadblocks, get those cases so that we can dig into it. And as the state looks at further at the rest of the waiver continuum of care, because there's many waivers involved, that we create a better blueprint that really facilitates this and doesn't prevent it. Thank you.
Thank you for the testimony. We are on page 40 of the agenda. I'll entertain a motion to approve the staff recommendation.
So moved.
Call the roll, please.
Monning,
Aye.
Mitchell,
Aye.
Thank you.
Moving on to issue 10, Medi-Cal PACE modernization.
Thanks. So we have proposed trailer bill that relates to improvements that we see are necessary to the PACE statutory provisions. There are 4 major components that we've laid out. First, in terms of rate setting, so currently today, the PACE rate setting is completely different from the rest of the managed care rate setting. We actually rely on fee-for-service data to establish a fee-for-service equivalent and set the rates that way. That has become essentially impossible for us to do moving forward because, as you well know, we don't have that many populations remaining in fee-for-service, and so the data has become really not reliable for that purpose. In addition, we do see benefit in, let's find out what is the actual experience of the PACE organizations and use their own cost and utilization information to inform the rate setting, which is how we do rate setting for the rest of the plans. And so this trailer bill proposal would shift to this actuarial equivalent, so using their actual own data on cost and utilization to set their own plan rates and move away from data that is no longer reliable for us to use. Second, we do propose to have the ability for the department to seek flexibility from the federal government for the PACE organizations to better streamline the program, to remove some of the administrative barriers. So one example would be to allow for alternative care settings and the use of community-based physicians. Third, we propose to remove the statutory cap of 15 PACE organizations that exists. And then finally, we propose to align the state law with recent federal changes that used to require that PACE organizations be nonprofit. That has been removed at the federal level, and so we would like to make that conforming change. In terms of how the new methodology would likely impact rates, we actually don't know the answer to that yet. That's why you don't see a cost or a savings tied to this rate methodology change. We don't have the data yet to make that determination. We actually have an actuarial work group that's formed with department staff as well as the PACE organizations to inform what would the data collection look like, what do we need to do, how do we do it differently from what's with our existing managed care plans? Because we do acknowledge PACE organizations are different as a managed care plan. They have capital issues and different things. They actually have locations. So how do we develop the data request, and then what is the rate methodology, and how do we make sure it's reflective of the people they're seeing and the costs that they experience that other plans wouldn't have? So we don't know yet. It's possible that the rates could go up. It's possible they could go down. It's possible they stay the same. But we need the accurate data to know that, and we think using their own data is the right direction to move in. In terms of new PACE applications, so the application is actually an extensive process. I think our PACE organizations would tell you that it takes a long time to get through being approved because it is such a challenging program to enter into, and there are a lot of requirements on the PACE association, the PACE organizations to provide that to meet all the federal regulatory requirements. We evaluate several key criteria that I'll just flag for you. First relates to market feasibility. So we look at is there a sustainable population that would potentially enroll into the PACE organization? We also look at the potential impact on existing PACE organizations. So would it just be moving people from one existing to another that wouldn't really increase the access for individuals? We also look at several elements related to financial means and viability. It is a cost-intensive process to start a PACE organization, and so we want to make sure that they're fiscally sound coming in. We also look at their organizational experience and capacity. Do they have the right people on board to provide the services to this particularly, vulnerable population? Do they have experience working in these types of areas? And then finally, the last piece relates to community relations and network capacity. So do they have demonstrated relationships with providers within the designated service area? We do request letters of support and commitment from local entities and providers and hospitals and others in the application itself. We consult heavily with CMS during the application process, as well as with our partners at the Department of Public Health, to ensure that the organization receives the licensing that it needs for any for the PACE centers. We also do work and inform the CalPACE Association so that they are aware of new applications that are coming in. And additionally, we do encourage the applicants to work with an approved PACE Technical Assistance Center, which can help new PACE organizations understand the requirements of PACE and get up and running.
I noticed, based on the comments in the agenda, that following recently released federal guidance, that you'll be permitting for-profit entities to apply as PACE organizations. And I'm sure we're probably going to hear some of the nonprofits commenting on that. But could you give me a sense from the department's perspective, what that will do to kind of the integrity of the program, and just what change do you foresee, that pretty significant shift?
So we don't anticipate that it would really change what we're looking for. So the same requirements apply to anyone who is applying to be a PACE organization. And so we will have the same standards. We'll be looking to make sure that the market analysis is done, that we're not negatively impacting existing PACE organizations. We'll make sure they have the experience that they need to create this organization, and that they have the support from the community in which they're trying to open.
And you don't see just kind of any kind of, how do I say it, shift in terms of just the nature of the PACE program? Will more for-profits get into the business?
Sure. No, I think from our perspective, it's a very high bar to become a PACE organization because of what's required. And so we don't anticipate, a situation where people would just be like, oh, now this is an opportunity. It's a high cost investment from the upfront, from the capital needs. It's not just opening an office. You actually have to have a PACE center. You have to have the experience and the knowledge. And it actually takes, again, I think you'll hear from our PACE organizations, the first year is very challenging in terms of operations. So we don't see it as opening sort of the floodgates to people being able to just come in and say, oh, I want to be a PACE organization. There's a lot of, high bars to pass in order to become that type of organization.
Okay, Senator Monning.
No questions.
Thank you, sir. LAO, Finance, public comment. First witness, please, 1 minute.
Good afternoon, Senator Mitchell and subcommittee. Thank you so much for the opportunity to speak before you today. My name is Erica Hawkes. I work for Ultimate Health Services, the largest FQHC in the country. Service your constituents in South Los Angeles, also a member of the LA Health Commission, as well as a proud constituent of yours, the 30th Senate District. Wanted to focus on the issue of appreciating the administration has put forward the language to modernize the payment and regulatory structure for PACE. If done correctly, this will enable PACE to expand and serve more older adults and frail seniors. We would recommend at this time that the committee keep this item open to allow discussion to continue. We submitted amendments to the committee and to DHS, and there's a couple of issues that we really want to focus on. One, we need the inclusion of the language that ensures that the payment methodology corrects for historic geographic disparities in the rates paid to PACE organizations resulting from access barriers in many counties. We also need changes that will ensure that the rate methodology takes into account the unique features of PACE that distinguish it from the traditional managed care plans. And finally, given the payment methodology has never been used for PACE programs before, we would like to see a hold harmless provision added to ensure it doesn't result in an actual rate reduction for individual PACE organizations. In addition, in the regulatory flexibility provision, we would like to work with administration on additional areas where greater flexibility could be provided, some of which could be done administratively. Regarding the provisions dealing with the lifting the cap of the number of PACE organizations and allowing for-profit organizations to operate PACE programs, we would like to see more specific guidance from the department and how it will ensure the implementation of these will not adversely affect existing PACE organizations that significantly invest in the communities we serve. So we look forward to working in continuation with the administration to come up with some kind of a solution to continue to ensure the quality service to our most frail population. Thank you.
Peter Hansel with CalPACE, the State Association of PACE Organizations, on behalf of our 11 members and roughly 6,000 seniors that we care for. Agree with the first witness. We also would urge that the item stay open so we can keep working with the department on the language. In response to the chair's question, we as an association do not have a position per se on the for-profit question, but we do have concerns, and many of our members are quite concerned. We do support the development of clear guidance and criteria for how applications are reviewed, particularly when there's an overlapping service area situation. I think hopefully we can get to that. Our biggest issues are on the rate setting part of the language, and I think the first witness outlined some of the significant concerns. So we do appreciate the changes the department's brought forward. We do think there are several important principles that are still missing in the language that we'd like to continue to work on. One of them is the historical rate disparity issue, which was mentioned. Another is greater protections for startup programs. As Ms. Cantwell said, it's very hard to start a program. They typically lose money. We actually think the proposal could make that worse, which is not what we'd like to see to expand PACE. We do support a hold harmless of some kind. This is a very uncertain area. I think Ms. Cantwell acknowledged that. Nobody knows what's going to happen to the rates. We think for that very reason, there should be a protective provision in place, at least transitionally, to ensure that this does not result in adverse rate impacts. Many of the PACE organizations have built their programs, their expansions, their commitments, their capital investment on the current rate structure. It would really undermine that if the rates were to change dramatically. We also, and this is the last point I'm going to make, we really think the rate methodology needs to recognize the value of what PACE does, and I think Ms. Cantwell did touch on it, but PACE is all about keeping people out of nursing homes and hospitals who are very, very frail. The rate methodology, as it's evolving, we're not sure would continue to incentivize that. There's really no mechanism that would give a PACE program credit, if you will, if they did a better job even and did in terms of keeping people out. We think that's maybe a generic problem with managed care rate setting, but we're really troubled in a value-based program to see that imported into the PACE arena. So for all those reasons, we do support keeping it open, hope we can get to resolution, meet the department's needs, but also protect PACE. Thank you.
Dion Arender on behalf of the Center for Elders Independence, which represents the East Bay of the San Francisco Bay. We want to align ourselves with the remarks you've heard from the two previous speakers.
Peter Kellis on behalf of St. Paul, San Diego, which has about 535 PACE enrollees. Two comments very briefly. Appreciate where the department's coming from and their acknowledgement of the complexity of the issue. Secondly, in terms of the rate setting, if the department is going to use MCO data, that they focus on the subcategory of individuals who are receiving the same services as PACE individuals to ensure accuracy of the rate development. And many PACE programs do things that cannot be measured in terms of Medi-Cal or Medicare data, hygiene, optometry, dental services. Want to ensure that those things are all incorporated into it and register the same remarks with regard to where we are in the item.
Madam Chair and members, Trent Smith on behalf of Cal Optima in Orange County. They operate the only PACE program in Orange County and like to associate my remarks with the previous speakers with regards to the rate issue.
Nicole Wertelman on behalf of Innovage, a PACE organization in San Bernardino. We want to associate ourselves with the comments. In particular, we are concerned about the geographic rate disparities, but we also wanted to thank DHCS very much for their continued engagement and working with CalPACE and all of the programs.
Excellent, thank you very much. And we will indeed hold item 10 open. Let's move on to issue 11, Every Woman Counts program. We're on page 44 of the agenda.
So we are requesting an extension of three-year limited term expenditure authority for resources equivalent to 3 staff in Every Woman Counts to continue to meet the grant requirements and to monitor the quality of breast cancer screening procedures that the program offers.
LAO? Finance? Senator Monning?
I'm prepared to move at the appropriate time.
I appreciate that. Is there any public comment on issue 11? Seeing none, the motion has been made. Please call the roll.
Mitchell?
Aye.
Monning?
Aye.
Thank you.
That's out with a 2-0 vote. Issue 12, Office of Family Planning contract conversion.
Sure, so this is a request to convert existing contracting expenditure authority into 10 permanent positions and expenditure authority for the evaluation and reporting of this program. There was a question about how we would ensure that the evaluation remains objective. Certainly these positions will be filled by professionally trained research scientists with the credentials to conduct research and evaluations. We have those types of individuals today in the department in various areas, including our Research and Analytic Studies Division, who do provide well-recognized independent evaluations. The evaluations obviously will also follow national standards and guidelines. We'll be publicly reporting that information so that folks can see that, including data on the Open Data Portal. We're also looking to add academic researchers to our stakeholder group to review the evaluation plans and assist with the interpretation of the results if that's needed.
LAO?